Assalamu alaikum and hello everyone. I welcome you all to the Symposium 5 with the theme of Managing ACLF in 2020 in the 14th Annual Conference of Pakistan Society of Study of Liver Disease on behalf of PSSLD. I'm Dr. Farhana Kayani, Consultant Gastroenterologist at Bolan Medical College Hospital, Quetta. So in this session, you will all come across the recent advances that are done in diagnostic and therapeutics in the field of managing acute and chronic liver failure. And as we all know, itself is the emerging and a challenging disease. And the chairs for our session are all well-known names, including Professor Saeed Hamid, Professor Altaf Bakir, Professor S.M. Munir, Professor Arif Amin Nawaz, Dr. Farina Hanif, and Dr. Nusrat Yar Khan. So our first speaker is Yogesh Chawla. He is Director at Postgraduate Institute of Medical Education and Research, Chandigarh, India, and he will talk about ACLF reversal and ACLF again. So over to you, Professor Chawla.
Good afternoon, everyone. I'm grateful to Professor Zaigam Abbas, my dear friend, and his team for having invited me to this very important meeting of the Liver Society of Pakistan and asking me to talk on a subject about which there is no literature available. So thank you very much, Zaigam. We know that liver failure is a very common medical ailment, and we are more familiar with acute liver failure for many, many years, where the patients come to you with hepatic encephalopathy, with coagulopathy, but they do not have a pre-existing liver disease. But something which has come up in the last decade or decade and a half is acute on liver failure, where it is acute liver failure-like picture, but two insults occur over the liver simultaneously. There is an underlying chronic liver disease, and the acute insult could be because of different reasons. So the patient becomes jaundiced, has coagulopathy, develops ascites within 4 weeks, with or without hepatic encephalopathy, and a mortality of about 40% is seen at 4 weeks. One of the recent studies, especially in alcohol-related acute on chronic liver failure, showed that resolution is seen in about 49% of cases, fluctuating course in about 30%, and worsening seen in about 20% of cases. So how does the Asian Pacific Association for Study of Liver define ACLF? This is following an acute hepatic insult when the patient develops jaundice of a bilirubin of more than 5 mg/%, coagulopathy with an INR of more than 1.5, ascites within 4 weeks with or without hepatic encephalopathy in a previous diagnosed or undiagnosed patients with chronic liver disease. And this mainly includes cirrhosis liver, but also includes chronic hepatitis like NASH or hepatitis B related chronic hepatitis. We need to differentiate a PASL definition from the ASLD or EASL definition, where they say that the duration in which there is higher mortality has not been defined in a PASL, but it is up to 3 months by the EASL consensus. Duration between the insult and ACLF is 4 weeks. It's not well defined in EASL. The chronic liver disease in a PASL includes cirrhosis and chronic hepatitis, but EASL only includes patients with cirrhosis, including those with prior decompensation. The precipitants are the same for both the things. Sepsis is not an inclusion criteria in a PASL definition, but is an important criteria in EASL, and variceal bleeding, which is important in EASL, but there is no consensus as far as a PASL is concerned. So this is a broad differentiation between the two. Rajiv Jalan, who was the pioneer in starting this terminology of acute and chronic liver failure, categorizes through the World Gastroenterology Organization that ACLF could be classified as type A when it happens on a patient with chronic hepatitis, type B if it happens on a patient with compensated cirrhosis, and type C if it happens on decompensated cirrhosis. And the acute insult could be because of infection, and very often it happens with hepatitis B virus reactivation, hepatitis E virus, A virus, CMV. These are some of the causes. It could happen with parasites, fungal infections, and other infections as well. And there could be a non-infectious precipitant like alcohol, which has been taken in the form of binge in the last 28 days, drugs like anti-tubercular therapy, antibiotics, autoimmune hepatitis exacerbation, Wilson's exacerbation, following transarterial chemoembolization and following surgery. So these are the acute insults. And we had in Chandigarh categorized these insults into type 1 if the insult is because of a hepatic reason, and type 2 if it is because of the non-hepatic reason. And the underlying chronic liver disease could be because of alcohol, non-alcoholic steatohepatitis, which is a growing problem all over the world, hepatitis B, hepatitis C, and other causes of cirrhosis. Statistics from different studies have shown that the organ failures which tend to occur in these patients mainly is in the form of liver, seen in about 60 to 70% of cases, renal in 30 to 35% of cases, coagulopathy in 30 to 35%, circulatory failure in 17%, cerebral in 22%, and respiratory in 14%. And studies have shown that mortality is related to creatinine, hepatic encephalopathy, ventilation, and organ failures. The APASL came out with a score. There have been different scores by the EASL group, like CLIF, ACLF score, and others. But APASL came out with a score and graded ACLF into grade 1, grade 2, and grade 3, each of which was associated with higher mortality starting from grade 1 to grade 3. And they distributed points of 1, 2, and 3 with the level of bilirubin, the grade of hepatic encephalopathy, INR levels, creatinine levels, and lactate. And those who had grade 3 ARC ACLF score had a very high mortality. We don't usually use Child's Puke score or MELD score in ACLF because it does not include the extrahepatic organ failure, which invariably tends to occur in these patients. So, when is reversibility possible in ACLF? Firstly, it depends on the severity and number of organ failures. As I mentioned just now, that 6 organ failures can occur in these patients. So, more the number of organ failures, more is the chances of mortality. Less the organ failures, the chances of reversibility is better. It also is dependent on the functional hepatic reserve. How much of the liver tissue which is there in these patients is functioning. If you can manage the acute insult very early, it's important. Manage the infections which these patients have. You're likely to have reversibility of ACLF. And whenever reversibility happens, there is resolution of ascites, encephalopathy, coagulopathy, and bilirubin. It's usually the coagulopathy which reverses in about 7 days and bilirubin in about 19 days if the patient has to recover. And reversibility is more often seen in younger individuals, less creatinine rise, and low INR values. Complications form an important risk factor for mortality, and there is a dynamic model for the ARC ACLF where you find the score on the day of admission and do a scoring on the 4th day and 7th day. And if it is increasing, there is increased chance of mortality, and these patients should be taken up for transplantation. So how do you manage these patients of ACLF? Firstly, they need a ICU admission. You have to treat early the precipitating factors. The underlying chronic hepatitis and cirrhosis, if it can be corrected like hepatitis B, should be managed along with, or hepatitis C. The comorbidities have to be taken care of because the prognosis is worse if there is comorbidity. And one should pick up these patients whenever there is organ dysfunction rather than at a stage when organ failure has happened. Like renal dysfunction, you would say when the creatinine has risen just a little bit from its normal value, to organ failure, renal failure, when the creatinine goes more than 1.5, and you should follow the Akin criteria. Prognosis in these patients by these measures have improved over the years. So what would you do? IV fluids should be started immediately so that you prevent tissue hypoxia and organ perfusion is restored. Albumin infusions for volume expansion should be tried, and it's been found to be useful in managing patients with acute kidney injury and spontaneous bacterial peritonitis. Albumin has also a role in immunomodulation, so it picks up the reactive oxygen species, endotoxins, and other functions. There should be a low threshold for antibiotics. So at any suspicion of systemic inflammatory response, these patients should be put on antibiotics. In fact, prophylactic antibiotics are also recommended because these patients of ACLF, because of humoral and immune cell alterations, tend to have a very high infection rate, and there is increased bacterial translocation. One should remove the catheters as early as possible, correct the metabolic factors, try to improve the nutrition and frailty, as sarcopenia has been found to worsen the prognosis. And recent studies from the Institute of Liver and Biliary Sciences by Dr. Sarin and his team has shown that if you give carvedilol to these patients of ACLF, the survival is improved because it decreases the chances of AKI and SBP. And whenever AKI happens in these patients, terlipressin is a better modality of treatment than noradrenaline. It improves the survival and also decreases the chances of renal replacement therapy. It's been found that whenever these patients have hepatic hydrothorax, the mortality is high. So just taking you through some of the recent publications on ACLF by the APASL group, the drug-induced liver injury, this is a study from the ARC total group of 3,132 patients. 329 patients had drug-induced liver injury, and they found that they had a high MELD score, high CTP score, and the mortality was around 46%. Alcohol-related ACLF is extremely common in India and in the West, and this is usually more severe, associated with infections. There is gut dysbiosis. People have tried steroids. Response is less in ACLF as compared to severe alcoholic hepatitis, and because of the risk of infection. We in India are not very happy giving steroids because they ultimately land up with infection. So one has to balance the role of steroids and no steroids. And there have been studies where pentoxifylline, granulocyte colony stimulating factor, and fecal microbial transplantation has been shown to be of some benefit. Now, whenever metabolic syndrome is associated with ACLF, the mortality is high. In 30 days mortality is 32%, increases to 43% in 90 days. Obesity, people who have in alcoholic related ACLF have a higher MELD, mortality is much higher in them. Dyslipidemia associated with ACLF has a high ARC score, but the mortality is not high as compared to those with obesity. The other important group which is very common in Asia is hepatitis B related ACLF. And studies have shown that if you give antivirals as early as possible, especially in combination, the 3-month survival is better as compared to the group who's not given antivirals. And mortality is more in cirrhotics as compared to non-cirrhotics. The other constituent important group of ACLF is autoimmune hepatitis related, which happened in about 3% of patients which were collected by the ARC group. Most of these patients were seronegative. That means almost 50% of them were seronegative. Usually steroids are given for patients with autoimmune hepatitis, but this is controversial. The ARC study has shown that it has been shown to shorten the ICU stay of these individuals and improved 90-day survival. But those individuals with a MELD score of more than 27, severe coagulopathy, hepatic encephalopathy, and advanced age are likely to not respond to steroids and should be transplanted. And very recently, a study on acute on chronic liver failure after surgery noted that they have a very poor prognosis within 28 days of surgery, and especially in the group of patients who have low sodium, renal, and coagulation dysfunction at the time of surgery. Now, the only study which I came across where they did a long-term prognosis of ACLF survivors showed that, and they qualified these patients as survivors or reversibility of ACLF when they had crossed 3 months of the index presentation. And they found that hepatic reserve, but not the severity of organ failure, was important. But when they followed up these patients, the 1-year mortality was 20% after these patients having recovered in the hepatitis-related ACLF versus 14% in alcohol-related ACLF. And this mortality was dependent on old age, hypoalbuminemia, hyponatremia, and increased MELD. Follow-up was of 19 months. And this is very well shown in the chart where patients who have acute decompensation less than 1 year had a poor survival, whereas those who had acute decompensation more than 1 year had a better survival. And this is also further shown that repeated episodes of acute decompensation brings about an early mortality in these patients. So what is our own data from PGI, the Department of Hepatology? This is work done by Dr. Ajay Duseja and his student Saurabh Mishra, where they picked up 112 patients of ACLF who survived. About 69% of them survived. And when they followed up for 6 months, about 20 or 25% of them developed ACLF again. And in 20% of them, it was the alcohol recidivism, and remaining 80% developed infections of those who had ACLF again because of pneumonia, SVP, and urinary tract infection. And the second episode of ACLF was associated with a 65% mortality. So this is the only data that I could get. I'm sure most of the other centers would also have their data, but unfortunately the literature did not have any information on this. So friends, I would conclude now and say that ACLF is a growing problem all over the world. We need to do many more studies and try to find out what are the reasons for reversibility. How can we improve the reversibility? As I said, the prognosis has significantly improved over the years. So can we improve further the reversibility? But most important is, what is the long-term follow-up of these patients after they have recovered, so that ACLF, again, adequate precautions can be taken and these patients should not go back into ACLF. So thank you very much for the patient hearing, and it's a pleasure to answer questions, if any.
Thank you, Professor Chawla, and it was such an informative talk, and I believe it really helped us in better understanding of the disease. So for our next talk, I would like to invite Dr. Faisal Dar. He's transplant surgeon in Quaid-e-Azam International Hospital, Islamabad, and his talk is about when to transplant in ACLF. Over to you, Doctor.
Bismillahirrahmanirrahim. First of all, I would like to thank the organizers of this meeting for their kind invitation. The topic assigned to me was liver transplantation for acute on chronic liver failure. I think this is a high time we talk about the role of transplantation for acute on chronic liver failure. Acute and chronic liver failure is a syndrome which is characterized by hepatic decompensation resulting in liver failure, which is primarily defined by coagulopathy and jaundice. And there are associated extra liver organ failure, and that all summed up together is related with the high mortality in the short term, which is defined by a mortality at 28 weeks or 28 days or at 3 months. ACLF actually is present in 10 to 20% of all patients admitted to the hospital for acutely decompensated cirrhosis. And it develops in another additional 10% of the patient during the hospitalization. The overall 28-day transplant-free mortality ranges between 30 to 40%, underlying the need for urgent and aggressive medical treatment. Defining acute and chronic liver failure has been a challenge, and there has been more than 400 research papers in the last 14 to 15 years about acute and chronic liver failure. And still, there is a bit of a confusion in defining acute and chronic liver failure and to develop the prognostication models for acute and chronic liver failure. But by and large, there are three groups which has tried to define acute and chronic liver failure, and based on a good number of patients' data, and then they've tried to revalidate their original findings. One is by the Asia Pacific Society. The second is the European Liver Society, and the third, the North American Consortium for End-Stage Liver Disease. Overall, these definitions differ slightly, but I think the gist of all these definitions is the same, that a patient who had a chronic liver disease in the background, and then they suddenly develop jaundice and coagulopathy, they fit into the category of acute and chronic liver failure. And then a puzzle does not include the extrahepatic organ failures into the definition. However, the EASL group does. More and more organ failures involved in the process of acute and chronic liver failure leads to high mortality. And that remains difficult yet to define whether the organ fails as a part of liver failure or it's a product of liver failure. However, the EASL group have nicely defined acute and chronic liver failure and categorized into three grades based on the number of organ failures: organ dysfunction or organ failure. And as the number of extrahepatic organ fails, the risk of mortality goes higher up. And by and large, because these patients has chronic liver disease in the background, there is a trigger which actually triggers the acute decompensation process. And in Asia region, hepatitis B flare-up has been associated with acute and chronic liver failure. And the Western world, acute alcohol consumption has been the leading cause. What we have seen in Pakistan is that by and large it is triggered either by infections or actually drug-induced hepatic injury leads to acute and chronic failure. And most of the time we'll see patient has taken NSAIDs for some kind of a pain or used some herbal medications to get rid of their symptoms, and it triggers the sequelae of acute and chronic liver failure. However, in spite of the exhaustive examination, 20 to 45% of the cases, we won't be able to find a trigger of acute and chronic liver failure. And with increasing number of organ failures involved in this syndrome, the mortality goes higher up. And again, in this slide, you can see the cumulative incidence of death or removal from the wait list within the 14 days of registration As the time goes on, the mortality goes up. And again, it is highlighted in this slide with an increasing number of organ failures, and the time goes on, the mortality goes up, up, and up. Out of the research in the last 14, 15 years, the proposed algorithm for the management of acute and chronic liver failure has been proposed. And if the patient develop acute and chronic liver failure, we all now very clearly know whatever the grade of acute and chronic liver failure is, the mortality at 28-day is around 30% for ACLF1, and then it goes up. And with 6 months, the mortality goes really high. So these patients are actually benefited from transplantation. And this algorithm defines that if the patient has no clear contraindication to transplantation or active substance abuse, they should be assessed for transplantation and should proceed to liver transplantation until unless they are too sick, which has been defined by Aclf C ACLF score of greater than 64%, or they develop ARDS or uncontrolled infection or a refractory shock or ongoing active bleeding, then obviously they should be provided a supportive care, because transplant can be a futile effort in these patients. And again, this graph is highlighting more or less the same thing. And on the left-hand side, we can see with increasing time from the onset of ACLF, the mortality goes up. Like at 28-day after the symptoms, with ACLF1, the mortality is 21%, at 90 days it goes to 42%, and at 180 days it is 47%. And if you look at grade 2 ACLF, this is 57, 74, and 79%. And with grade 3 ACLF, it is 87% at 28 days, 95% at 90 days, and 96% at day 180. So it is very clear that with the increasing time and the increasing grade of acute and chronic liver failure, the mortality goes up. So patients who are in grade 1 and grade 2 acute and chronic liver failure should be aggressively treated with medical therapy, and whenever they get the opportunity to get a liver transplantation, they should be offered a liver transplantation. And this is what we have observed in our experience here in Pakistan. We have transplanted a decent number of patients with acute and chronic liver failure, and we retrospectively reviewed our own data of liver transplantation. We used the Aclf consortium criteria to define acute and chronic liver failure, and the grading of these acute and chronic liver patients was based on Aclf consortium criteria. So we divided our patients by the virtue of the treatment they got. One group was a patient who got liver transplantation as a definitive treatment for their acute and chronic liver failure, and the other group was which did not got liver transplantation. Either the patient did not want it, they did not have a suitable donor, or they refused to accept liver transplantation as a definitive treatment. And we observed these patients, and you can see that from these slides, there's a decent number of patients in both arms, like 58 patients in both groups. And these are the demographics. Predominantly hepatitis C was our main indication, followed by hepatitis B, cryptogenic cirrhosis. The standard decompensations which are associated with acute and chronic liver failure, like GI bleeding, encephalopathy, jaundice, ascites, all these are present in our patients. And majority of these patients got a right lobe graft. And you can see from this table that the 38-day mortality in patients who got liver transplantation was 4.6%, and the patient who did not got liver transplantation, it was 60%. And at 90 days, in the transplant group, the mortality was only 4.6%. However, in the non-transplant group is 80%. The post-operative complications were fairly standard in the post-transplant group, and the survival in the transplant group at 1 year was 92% versus 11% in the non-transplant group. That means at 1 year, 90% of the patient in the medical therapy group was dead. So I would like to summarize my talk looking at all the guidelines from all the different societies, that ACLF grade 1 and 2 should be listed for liver transplantation, even among patients who have recovered from an episode of ACLF. There is still an increased likelihood of developing a higher grade of ACLF in the future, and an inherent mortality at 6 months between 40 to 50%. Therefore, evaluating and listing these patients for liver transplant may build a safety net in the event of future deterioration and development of multi-organ failure. The presence of ACLF grade 3 should not be considered as an absolute contraindication for liver transplantation. There will be some patients in ACLF grade 3 which still can be saved and will benefit from transplantation. A patient with up to 3 organ failures or a Aclf C ACLF score of less than 64, as well as those who showed an improvement of ACLF grade in the short term, should be considered for liver transplant because they have a poor non-transplant survival and relatively a high post-transplant survival. And at the end, I would like to thank for your patience listening, and I will be very happy to take your questions.
Thank you, Dr. Faisal Dar, for such a nice talk. And our next speaker is Senior Professor Shiv Kumar Sarin. He is Head of Department of Hepatology, Director at Institute of Liver and Biliary Sciences, New Delhi, India. And he is also founding co-chief editor of Hepatology International. So in his talk, he will focus on new treatment options for acute and chronic liver failure.
Adab, greetings from the Institute of Liver and Biliary Sciences. It's a privilege to speak at the PSSLD. I had always wanted to. Thank you for the kind invitation. I would discuss new treatment options for ACLF. I have nothing to disclose except that we have very bright and young faculty, and we are ranked in the scholastic output as number 2 after the All India Institute in the country. I would like to draw your attention to the fact of how do we define liver failure. If it is a normal liver and there is an acute insult, you call it as ALF. And if there is already a decompensated liver, then you will say, yes, this disease has become further worse and it can result into sepsis, bleed, acute kidney injury or HE. We are talking about a patient who has chronic liver disease, F3, F4 fibrosis, gets an acute insult, and this results into liver failure. And there is a jaundice followed by ascites. Another group of patients may have compensated cirrhosis. They get an acute insult, and this acute insult, whether it is virus, alcohol, drugs or something, can result into different types of decompensation as a GI bleed, encephalopathy, ascites, hepatorenal, sepsis or a combination. We are only talking of one of these, that one type of decompensation where there is liver failure, that means there is jaundice and is followed by ascites, is acute or chronic liver failure. If you use this definition, you will have a homogeneous group of patients. However, if you use the Aclf or any other definition, you may have patients who have got HRS, who have got HE, ascites or sepsis, or they are decompensated. Therefore, the definition of ARC or ACLF by Apostle is quite different. Each one of these have their own natural history, that is a natural history of end-stage liver disease. Similarly, if you have patients who have gone to the ICU, they are on a SOFA scale assessment. This is by NACSEL, which is the North American group of people. I am going to discuss how, and the colleagues from Pakistan would learn well about what is ACLF as we mean today. So from the West, a condition occurring within 4 to 12 weeks of jaundice and or an inciting event. It's not necessarily jaundice, it can be sepsis, it can be anything else, which results in hepatic decompensation. So you may have a UTI, you may have a pneumonia, and 2 months later you may have jaundice. Or you must have 2 extra hepatic organ failures, means kidney or lung or something. It has a high mortality, and a lot of them are related to sepsis, bacterial infections, drugs or alcoholism. A Parsel arc definition is simple: bedside, hepatic insult, which is acute, bilirubin more than or equal to 5, INR more than 1.5, and within 4 weeks, so there is no confusion, and results in acute portal hypertension and or encephalopathy in a patient with CLD or cirrhosis with a high mortality, without any sepsis if the patient presents to you for the first time. Now, what is in a definition? Why have I given you as such an amount of discussion? You have to have a correct phenotype of the patient for a proper, purposeful treatment. I'll give you a case: 41-year male, BMI 33, who was taking complementary medicine during the days of COVID. And this complementary medicine led to jaundice for last 6 days and ascites for last 3 days. And liver was 13, spleen not corrected. On day 23, according to a puzzle, this patient had no SIRS but has ACLF. Why? You can see this patient has high INR and has jaundice, as I said, 23 millimeters. This patient, because of the tense abdomen, required modest volume paracentesis and was put on diuretic. On day 27, that is day 3 or 4 of Hassel's admission time, now he has got SIRS, he has got heart rate which has gone up, still calcitonin is negative, bilirubin is rising, INR has gone up, jumped, and now his creatinine, the second organ, is started to worsen. A transjugular was done, which showed F3 fibrosis, and he had an HAI of 5. Now this patient, we were giving NAT, diuretics were stopped, no plasma exchange was done. Now this patient on day 30, according to Easel and Cliff, now this patient has creatinine which is high, so he has a kidney involvement, so he has an extra hepatic, so he will be qualified now for ACLF. He has ascites, he had to undergo a repeat modest volume paracentesis. Now he was explained in need for transplant. We would have done or had done on the very 23rd day when he came to us. Now day 32, day 35, his create went up, he went into encephalopathy, pneumonia, noradrenaline, and finally he died. ACLF, liver is the driver. Jaundice, coagulopathy, encephalopathy, and high lactate. And then the kidney make that, yes, this is a sick patient. Our patient, when he came, bilirubin was 22.5, he had no HE, INR was not high, he was between 1.8, lactate was high, but create was normal. His score, according to the ARC score, was 10. According to the grade for liver failure in chronic liver disease, he was in grade 2 liver failure. Now see what happened to this patient on day 7. By day 7, his bilirubin was still high, he had INR, lactate, and now his creatinine started going up and his ARC score was 12. And therefore he had gone into grade 3 in 7 days. We could have said, yes, this is the patient. So what is the difference between the Apostle, Easel, Cliff definition? Apostle diagnosis without extra hepatic organ failure, and it only depends on acute insult and a yellow as it shows you liver failure. After a few days of liver failure, other organs start going down, and that is when Easel-Cliff diagnosis. And this gives you a window of 7 days which is lost or if you are wise, you can gain it. So now the choices are getting clear. World over, people are accepting the concept of the golden window. In the beginning, this patient, as our patient, did not have SIRS. Then he started SIRS, then he went to organ failure. You can have SIRS to sepsis or sepsis to organ failure. This generally is 7 days. So most patients who come at day 0 have no SIRS. But by day 4, as you can see, a proportion develops SIRS, and then a proportion will also develop sepsis while SIRS goes up. So this therapeutic golden window, my friends, colleagues, we should not actually ignore. The ARC score in our patient was 10. And this ARC score, if it rises from, let's say, 7, 8 to 10, then there is no problem. The mortality goes by 4%. But if a patient comes with an ARC score of 10 and above, like in our patient, any single rise of 1 unit, 10 to 11 or 12, you will have a rise, and these patients can increase mortality by 20%. So therefore, we should be very careful for timing for liver transplant, referring and interventions. On defining ACLF on organ failure, what Cliff is doing is late. In fact, we were the first in the world to publish in 2012 before the studies by Risha Moru and others. This study shows one organ failure, you will have a mortality which will be just about 7. 7 is dead out of 25. But as the 2 organ, 3 organ or 4 organ failures, mortality will be higher and higher. And it looks quite logical. But we don't want to go to the stage when organs have failed and you are saying, now I can't do it. How do we treat? This is the main target for my talk. First is to make you realize the concept of acute portal hypertension. Ascites is coming within 4 weeks and variceal bleed. So what happens in ACLF? Huge amount of cytokine burst. You are all aware in COVID times. Activation of stellate cells. You may not have varices, but portal hypertension is rapid. So we have a very large number whom, when you do endoscopy, they have no varices, but HVPG pressures are close to 18, 20 because of stellate cells, endothelial dysfunction and impaired vascular relaxation. A cirrhotic already has raised portal pressure. Now you have an acute hepatic insult. So acute rise in portal pressure from 12 maybe to 20. This leads to high risk for developing ascites, HRS because the blood is reshuffled, GI bleed and encephalopathy. Now this study shows when you give carvedilol, it can improve the outcome in ACLF. Here is time and here is the percentage. If you give carvedilol compared to placebo, 28 days survival is far better. Not the 90 days because that depends on many other things. But you can improve survival by acutely decreasing portal pressure. Now, this is to show that those where you give beta blockers or otherwise spontaneously, if the portal pressure decreases by more than 20%, then the varices don't form. Much less compared to if the pressures don't decrease. Also, AKI is decreased. I'm not showing you all the data on this particular thing. The second part is these patients develop ascites. This is like very tense anteroposterior abdomen. This is not the flabby side where you have flanks which are full. ACLF ascites is anteroposterior. And this is a huge increased intra-abdominal pressure. So our hypothesis was ACLF patients develop paracentesis-induced circulatory dysfunction early with small ascitic tap. We call it as MVP, modest volume. This is because in these patients, hemodynamic disturbances are tremendous. This is to show you if you give albumin versus no albumin, there is a significant increase. 70% will have PICD after tap. And that is just 4 liters, not 5 liters. And albumin, even if you give 30% will have PICD. To just therefore summarize, PICD is more common in ACLF, 70%. Modest volume, 3 to 4 liters is ideal. Albumin reduces mortality. Normal plasma renin is less than 4 or so, actually 2. But in the patients who have got ACLF, they have already maximum PRA. And if the PRA is around 24 on day 3, PICD will develop on day 6. So plasma renin means that hugely activated sympathetic system. Our patient had repeated MVP. He did not develop PICD because we gave adequate albumin. You remember, our patient came with tense abdomen. On 23rd day, we had to do acetic tap. And if you do PICD, if the patient develop, it will add to AKI. The second problem is progressive rise in bilirubin. And our patient on day 23 had bilirubin of 22.5 and it was rising. INR was rising, coagulopathy was rising, lactate was rising. How do you manage it? There are no new treatment options other than liver transplant, but yes, therapeutic plasma exchange should be tried. Why? It is a detoxification, it allows the biosynthesis to improve in the liver and homeostasis can be done. So pathophysiological changes and basically removing the damage associated molecular patterns and other toxins can be achieved by plasma exchange. This study, which is now in press, compared to the Prometheus or Mars, if you do plasma exchange, there is an improved cumulative survival at day 90. And therefore, I would suggest plasma exchange in a patient who has got ACLF and does not have sepsis can be tried. Our next problems are patients have underlying diabetes or obesity. A recent publication from ARC by Dr. Duseja from Chandigarh shows these patients have a poor outcome. I will now discuss briefly about sepsis and preventing infection and extrahepatic organ failures. In patients with ACLF, within 24 hours, and we have data I can't show you, neutrophils lose their functions. Monocytes stop expressing HLA. Their T cells are also marginalized and dendritic cells are also not functioning. We believe and have shown that sepsis is a consequence of liver failure. How do you prevent or treat? The immunoparesis can be partly reversed by giving GCSF or GM-CSF. In a patient who has got chronic liver disease or cirrhosis, acute insults like toxins and viruses cause ACLF, neutrophil dysfunction, which leads to sepsis and then liver, renal, and hepatic encephalopathy. Now, if you give in these patients GCSF or you give some immunomodulatory agents, it will improve the DC function, it prevents the neutrophil to become bad, sepsis is prevented, and then other dysfunctions, renal and others are improved. So prevent sepsis to prevent organ failure. Patients of ACLF have HE, and it is seen in close to about 60% in grade 1 or 2, and a proportion of these have 40% of them of the total HE can be grade 3 and 4. For acute liver failure, ammonia above 120 is associated with high mortality, but ACLF more than 143. You can do plasmapheresis or ammonia targeted test. Another major problem in ACLF is early renal impairment because of cholemic nephropathy. High bilirubin clogs the tubules. Now, if you have a patient who has a newly diagnosed AKI, like creatinine has gone to 1.4 or 5, you may try and give them volume and albumin. The patients may respond. Only about 30% or so will respond. If there is no response, it is functional HRS. Vasoconstrictors should be started early. Terlipressin is a good drug, but does not work very well if the bilirubin is above 12 or so. These patients, you should wait for 24 to 48 hours. If there is no response, you have to think of other alternative therapies. Therefore, patients with ACLF with AKI have a very poor prognosis. ARC has a huge database now of about 7,300 patients, and we are very grateful to our colleagues in Pakistan who continue to guide us and contribute to the database. Our patient had toxicity, and there is a new consensus which is coming up on DILI. ACLF secondary to DILI has a high mortality. Early management is imperative. Drugs can be CAM, ATT, ART, methotrexate, and others. Anyone with an ARC score above 11 or a MELD of above 30, early transplant should be done. Liver transplant is the final savior. I don't have the time, but I'll just give you the algorithm. A patient with ACLF comes, sepsis must be immediately assessed to optimize antibiotics and prevent organ failure. If the ARC score is 11 or above or MELD is above 30, this patient straight away goes to transplant in the absence of sepsis. Now you have an ARC score after managing medically which comes to 4 to 7, then you can actually do medical therapy. On the other hand, if the ARC score continues to rise, he goes for an emergency transplant. Extrahepatic organ failure other than liver, let's say it is brain or it is lungs or it is kidneys, such patients need plasmapheresis. If they are stable and they improve, they can go for emergency transplant. If they are not improving, supportive care. Or a patient who comes at the beginning, according to Cliff and others, these are the patients who come. And they have a cadaver program. Where is the cadaver program for us? We have to have DDLT, improve, but we have only LDLT. So such patients, if they come in our setup with 4 organ or 2 or more organ failure, most of them end up with supportive care and death. Therefore, I think we have to try picking up patients early using the ARC score, which to my mind, honestly, is the best score available. So one more time, I would like you to go through this algorithm and say, our aim is to bring the ARC score to less than 10, otherwise it will remain a futile exercise for us. I would like all of you to contribute to enrich your journal. Your journal is Hepatology International, which is the apostle journal. It has a good impact factor. And I also urge each and every one of you in PSSLD, the experts and the other advisors to join ARC. With this, I bring you one more time greetings from ILBS and thank you for inviting me for this very important week. Thank you.
Thank you, Professor Kumar, for such a wonderful talk. And now it's time to get comments from our chairs. Yes, Dr. Arif.
Thank you, Farzana. I have, before the conclusion comments, I have some questions for the Dr. Shiv Sarin. Sir, you're able? So can you hear me? Is Dr. Shiv Sarin available online?
Please check your mics. They should not be on mute. So, can we quickly check communications with everybody? You can leave your mics on, and if Dr. Chawla can say if he can hear us, can you just want to make sure we can hear you?
I can hear you.
Good. Dr. Sarin, we still can't hear you. Dr. Faisal Dar, can you hear us?
I can hear you, but I can't see you.
Dr. Faisal Dar, please turn off your video. There is Dr. Sarin there. Dr. Sarin, can you hear us?
Yeah, I can hear you now.
And we can hear you very well. Thank you.
Okay, Dr. Sarin, this is Dr. Fadina. I have some questions for you.
I can't hear the question.
Okay. Sir, can you hear me now?
Yeah, I can.
Okay, sir, I just want to know that as you mentioned that the carvedilol using carvedilol in acute liver failure patient has a good improvement or better survival rate. The question I want to know that as in encephalopathy, carvedilol is contraindicated. So in patient, do you mean by giving carvedilol in those patients who presented with jaundice and later developed ascites, or before developing the encephalopathy, or can we give the carvedilol with acute and chronic liver failure even with encephalopathy?
Yeah, it is not for acute liver failure. It's acute on chronic liver failure, which already has portal hypertension. And development of ascites is an acute exacerbation of portal hypertension. In these patients, any beta blocker, propranolol or carvedilol, can be given. However, you have to maintain the blood pressure. There is no contraindication with bilirubin levels. Only contraindication may be renal dysfunction.
Thank you, sir. Sir, another thing which is I want to know that do you have any experience with using NAC therapy in patient with acute and chronic liver failure without the history of DILI, like in cases of autoimmune or viral hepatitis?
NAC is a good drug, but most patients, I feel, it works like placebo. The amount of sodium it delivers and the amount of rise in glutathione is imaginary, and therefore I do not use it as a routine, or any one of us uses in ACLF. Yes, it has been shown in some studies in non-paracetamol ALF, but has very little basis of using in ACLF. In patients who got drug-induced liver injury, we prefer directly glutathione, which is precursor and better drug than NAC.
Thank you, sir.
All right, sir. We have a question from the audience. The question is like, keeping liver transplant aside, how do you see stem cell therapy in future as an option for treatment for ACLF? By Dr. Mukesh.
It's a very good question. I think it's an option which has not even been explored well. Mesenchymal stem cells are strong immunomodulatory, and by paracrine mechanisms they work. In our earlier work, we were using GCSF to modulate the stem cell derived factor SDF1. If you decrease SDF1 from the bone marrow, you will release hematopoietic cells as well as MSCs. So I think using GCSF in low dose, not the 300 microgram, but a smaller dose, and in patients who have got a MELD which is less than 20, you may have benefit of decreasing sepsis and improving the new neutrophils, the new monocytes, the new myeloid cells. Now using stem cell therapy from umbilical cord or from MSC, it's a challenge. We do not have data, but science says they should be used. There is enough basic science evidence, but we haven't, and I wish we will do it.
Thank you, Professor Sarin. My one question is to Professor Chawla. Professor Chawla, we also have started seeing alcohol-related ACLF in Pakistan, and the problem that we face is that we have to look into two aspects. One aspect is alcohol-associated liver disease, and second aspect is alcohol use disorder. So we consider one aspect and we forget about AUD, which is alcohol-associated alcohol use disorder. And I saw your slide about the high rate of recidivism that you see in your patients in India. So how do you coordinate two activities of AA, LD and AUD in your patients? Because why there is so much recidivism and why people come again and again?
That's a very good point that you raised. Recidivism anywhere is there. Even if you transplant a patient with alcoholic liver disease, recidivism is there in about 15 to 20% of cases. And I think the same thing holds true for patients with ACLF who have recovered. But as a policy, all these patients are given a psychiatric counseling for de-addiction. Most of them adhere to it, but there are a significant proportion who don't adhere to the counseling. So 20% is a figure which goes with the liver transplant patients also who had alcoholic liver disease.
So how are you assessing your alcoholic ACLF patients with MELD scoring or Medri discriminant index or any other scoring?
No. It's by the ARC score.
Those who have
ACLF, most of the severe alcoholic hepatitis would have ACLF. Very few of them would, and that is with the help of ultrasound, hematological investigations. You get a rough inclination whether the patient has underlying chronic liver disease or not. Biopsy is not possible in all of them. So most of them are.
Thank you very much. My one question to Professor Sarin. Professor Sarin, we keep on asking you again and again, but excuse me for this. The ACLF again, how do you throw, because there is always confusion because acute decompensation and followed by decompensation again and ACLF again. So, and the reversibility of ACLF after again. Professor Sarin?
Thank you. Professor Chawla had very well described this term. You remember in 2019 brought this concept of ACLF again in the ARC consensus meet. The idea is that patients who have recovered, and if they especially are drinking alcohol, what happens? And this paper has just been accepted 2 days ago, that if the patient has been admitted once as ACLF, if he drinks the second time, mortality is less. However, the risk of readmission remains. So ACLF again probably is a lesser disease than in the first time. The only indication of using this term is in alcohol, neither in Hep B, nor in Hep C, nor in drug-induced, nor in HEV. So I think alcohol and alcoholic liver disease pose a huge challenge for us. The next big challenge to me now is the complementary and alternative medicine, where ACLF again comes. Patients who have taken first like an indigenous Ayurvedic or maybe some local drug, they have, and now they come to us, they get a discharge and they start on something else. Now every other drug in these DILI patients works as a mimicry, they get ACLF again. So person who has got DILI and ACLF should be kept off the drug. So there are two specific groups, both are toxins, alcohol and DILI, where I think chronic drug-induced liver injuries can be difficult. Whether we should include it into our definition, I think we need larger data, but I'm inclined that we should have a category of such patients.
So there are other group of patients like we see in autoimmune liver disorders and hepatitis B flares, because another problem that we see in our country is the non-compliance. Like hepatitis B, they keep on taking drug and then after a few months, because they are coming from far-fetched area, and then they stop drug. And autoimmune patients again, because sometimes they come up again with flare. And so in our database, are there any cases of autoimmune liver disease or hepatitis B flare who ended up with ACLF again, or we do not have enough data?
That's a brilliant question. Very, very good question. We have not analyzed these two sections, and I would be happy if you would like us to make this happen. Just for your and others' information, we are simplifying the R pro forma, which will be a drop-down menu. Maybe by 1st of January, you will have a 5-minute simple pro forma, and one can fill it every day. But right now, we don't have HBV or autoimmune ACLF again. Very good question.
We have Dr. Altaf Alam along with us. Dr. Altaf Baqir ji. Dr. Baqir, can you please share your experiences regarding ACLF?
Thank you very much, Professor Chawla, Professor Sarin, and Professor Faisal Dar for fantastic talk. Yes, we had a few patients of ACLF, and majority came late, and the prognosis was bad, and they were not willing for going liver transplant. This is again a financial issue. This we often see these patients. I think if I would say 3 or 4 patients in a year, but these patients are managed the periphery, and most of the time when they come to us, it's too late for them to survive. Thank you.
Faisal, we had a question for you. I guess if you look at our audience, which is there right now, there are a lot of patients in the periphery quite far away from the transplant center. And this is a general question for all three of us, for all three of our speakers. What are the steps that you would expect a physician sitting in the periphery out there to, first of all, detect this condition, and then if they can take certain steps to before they send these patients out to you guys in the transplant center? Faisal, can we start with you? The referral process and the very few quick 30-second steps that we can take before we send them out?
Thank you very much. I think, first of all, when I started to learn about ACLF, actually I was a transplant fellow and I was listening to Professor Shiv's talk. And that terminology struck me, and that was more than 10 years ago. I think we have the pioneer of the concept, and he will be in a better position than me to guide. It took me 10 years to understand and accept that ACLF exists. And when I attended that talk, and we were having conversation in the hall, and people were saying that actually this is nothing new, this is all rubbish. ACLF actually does not exist. It is just the decompensation of the liver disease. But I think credit to Professor Shiv's consistent hard work that he has made the world to accept that this is the entity which exists. And a lot of work from him has been published, and now slowly and gradually we are developing the understanding that ACLF is an entity. To be very honest, I myself is very confused at which definition of ACLF to adopt. And our other application is very simple and straightforward. The flip definition is a little more complex. But coming back to your question, I think whenever internists or gastroenterologists sitting in a small town see a patient and they have fulfilled the definition of ACLF by a puzzle that is a bilirubin of greater than 5 and iron of greater than 1.6, that patient should be referred to our regional liver unit for further assessment and treatment. What we have seen in our paper, we compared the transplant and the non-transplant group. And at 1 year, the non-transplant group, 90% of the patient was dead. So I think in our setup, because the treatment maybe is not that robust and clear, the follow-up is not that really guarded. And most of the time, actually, you can blame the patient whenever they're better, they don't actually adhere to the guideline. So whenever I think patient hits the definition of a puzzle, they should be referred to at least a liver unit, not a transplant center.
on the same issue
I
of,
think
Dr. Chawla, go ahead, please.
it's very well said by Dr. Dar that more awareness about ACLF. Anyone coming with jaundice and ascites, one should suspect ACLF and refer to a liver unit where transplantation facilities are available. I think one aspect which we have not covered and which is likely to be bothersome is the fungal infections that tend to happen in ACLF. So a lot of patients don't respond to therapy, and infections, bacterial are though very common, but fungal infection also is a growing problem. And I wanted to know from Dr. Abbas whether HEV is still a problem of ACLF, or what they had published many years ago. Does it still form a major chunk or not?
Yes, so we do see from time to time such cases who have the chronic liver disease, and then they present with decompensation or criteria that APASA criteria for ACLF, and they have positive IgM antibodies for hepatitis E. So hepatitis E has not gone away, but it is still there in our part of world.
Okay.
Okay, so Amna Subhan here, and really this is like a great experience to see you all here and listening you again from here. And I can recall when we visited in 2014 to New Delhi, and we all met together. It was a great experience, discussing, starting at 8 and finishing at 10. So this is what Dr. Sarin has actually made sure that we all are like working and contributing, but this is really a learning experience and good memories actually, and I'm getting nostalgic after seeing you. So two questions which we actually face during our daily routine life. A, for instance, like in Pakistan, the liver transplant centers now are, but they are limited. So when the patient comes with ACLF, this is a challenge that when we should transfer them to a liver transplant center, because this is not present in every city. So what do you recommend that what should be an approach for the countries where liver transplantation access is like there is a scarcity to reach to a liver transplant center, when they should be transferred right away when they are coming, after some time, or what? A. Two, many of our patients are actually, they present with sepsis. So for how long we should be waiting for their sepsis to get better, and then we can re-evaluate them for whether they are transplantable or not?
Yes, I'll briefly answer. ARC is a very good model. If ARC score, which depends upon bilirubin, INR, HE, lactate, and creatinine, any small district place can do it. If ARC is less than 7, hold on. 7 to 10, refer. 11 and above, transplant. So up to 7, all physicians in a good hospital can manage. It is the liver failure and preventing. Now, second part is sepsis. The sepsis would develop after 7 days to 10 days, SIRS and sepsis. You manage nutrition, prevent by giving antibiotics, and thirdly, do not give drugs which are not required. I think many patients can be managed. However, if there is a rising bilirubin and there is a lactate rising, this patient should be referred. In a non-transplant option, first choice would be a plasma exchange. And if there is no response and the renal replacement therapy is available, I would give Turley plus albumin for a short while. Otherwise, albumin is not recommended in ACLF patients. I would also give drugs to reduce portal pressure so that patients do not have redistribution. So Turley is okay, but about 12, it doesn't work so well. So second vasopressor at a good center should be started. Of course, feeding and nutrition, so putting a rice tube and feeding them well is a very good option.
Would you like to briefly comment on, we
Thank
do
you.
see HEP in the context of pregnancies. and we're still seeing some liver failure. Would you like to comment on that?
Yeah, Hep E in pregnancy is a challenge. If it is a patient who is primipara, has HEV, and the fetal heart is okay, in the second trimester, you should monitor very carefully. In the third trimester, an early, delivery or cesarean, maintaining coagulation is required. It is important to keep the mother alive. Of course, both, but keeping mother alive is more important. And several times we transfer patients here. They get delivered in the morning, and by night or next day they're taken up for transplant, living donor transplant or something. However, I think very, very important in these patients is to monitor, because fetus works as a deterrent to the mother. So early cesarean or removal is sometimes helpful in these patients. And antivirals do not generally work. You can give Riba, but I think Riba makes things worse. So SOF can be tried. Otherwise, just manage as any liver failure. But fetal is more important for making the mother survive.
I wish this session could continue for another few hours, but I can see Amna's face and Zagam's face that we are coming to that time of when there's crunch time and there's lunch time now. But I really want to thank all of you from the depth of my heart that you were part of this symposium. And I think it must be very hard to sit there and listen to yourself saying something, and you always think, oh, I said this probably, so. But thank you so much for being part of this effort, and I want to congratulate PSSLD again for bringing us all together. And in spite of all the COVID and everything, I think we heard each other. Memories came back, and we were able to share our experiences. And I think this is the way forward. This is a sustainable reimagining of our lives. So unless we really eradicate this thing. So thank you very much again, and we look forward to seeing you again very soon, hopefully physically. Please close up.
Thank you.
So,
Bye-bye.
moving on to our quiz section. So we have this quiz
Great.
time now.
Thank you very much.
अच्छा, the first question is like वो तो दोनों आ गए जी दोनों एक जल
Jalpa का जवाब नहीं देगा. There has to be someone else.
Doctor, so we have this question. Yes.
ये साजिश है.
Ajit.
नहीं वो
So for question number 1, Dr. Ajit,
Ajit.
and for question number 2, Dr. Suresh Kumar.
Yes.
I
Agree?
just want to say that ये जो quiz है, this is again a test of wits. But for the speakers who were there, we just put these questions from outside from your talks in there and see how much attention were people paying, and they do get a cash, which actually is a credit for the next meeting. But I don't know. I hope they'll get some cash out of it.
So in this quiz, for first question we have Dr. Ajit, and for the second question we have Suresh Kumar. So with this, our session comes to an end, and I hope that everyone find it very helpful in clarifying and better understanding of the disease. So we will.
Okay, so just 2 house announcements, Ajit and Suresh, if you could just share your contact numbers. So we will be actually sending your prize money by some means shortly. So we will be meeting back after lunch at 2 p.m. and there will be like symposium for managing complication of cirrhosis in 2020. So the rest of the day and evening is again very excited. There is a symposium about portal hypertension, vascular diseases, hepatitis C, B and D, which is so common here in Pakistan, and nonetheless non-alcoholic fatty liver disease. So the remaining day is actually full of lots of sessions with world-class speakers. So please join back at 2. We'll be right back at 2 p.m. Looking forward to see you all again. Thank you very much.